everyone. First of all, at the outset, I would like to thank Dr. Kumar Prabhash sir, my teacher as well as mentor, for giving this opportunity, and all the organizers. And also thanks to Kumar sir for priming everyone and making everyone attentive. So now the very important discussion, neoadjuvant versus adjuvant. I hope Mridul Malhotra is online listening to me, the points which I'm making. I'm going to debate regarding neoadjuvant, why we should give neoadjuvant in lung cancer. So if you see, as the stage increases, the outcome of the lung cancer, be it a clinical or pathological stage, as the stage advances, the outcome is going to be dismal. If you see, the recurrence are pretty high from stage 1B to stage 3. These are considered as curative lung cancers. So if you see the analysis, like the analysis from both AIMS, TMH, as well as PH Indiger, significant proportion of curative cancers fall in stage 3. This is the TMH data by Narona et al. And this is the PGMR data by Kaur et al. Significant patients fall under stage 3 apart from the metastatic setting and curative setting. So, and stage 3 is quite heterogeneous. It is not equal, my friend. It's quite heterogeneous. Incidental N2, potential resectable N2, unresectable N2, multiple. It's a bag of different clinical conditions. And we have to be very open regarding the treatment options. So considering for the timing of treatment options in early cancer, these are the pros as well as cons for the neoadjuvant and adjuvant setting. So the Vanderby et al. After significant analysis, he said that an increased percentage of patients completing the planned dose of chemotherapy, that's the compliance to chemotherapy, is very high in neoadjuvant setting. And the ability to treat the micrometastasis, the tumor cell dissemination preoperatively, is very high with neoadjuvant therapy. The ability to evaluate the response to chemotherapy as a prognostic indicator. We all really hear a lot about this in breast cancer, but lung cancer, it's upcoming and validated data. But there is no improvement in resectability pertaining to chemotherapy. That's a neoadjuvant chemotherapy versus adjuvant chemotherapy. So later, like I just want to discuss, brush up regarding the chemotherapy trials, neoadjuvant versus adjuvant, NATCH trial. It's a very famous trial. It's like the first ever trial which was validated among all the oncology peers. It's neoadjuvant versus adjuvant was studied. This is the trial design. And significantly, the absolutely two curves are bang on. There is no difference in the outcome. The 5-year DFS is like equal in both arms, both neoadjuvant as well as adjuvant. But more patients were able to receive preoperative than adjuvant treatment. And the retrospective analysis subsequently, Brand et al. Published, it also showed there is no difference in the DFS or OS, be it a neoadjuvant or adjuvant. The similar thing we have seen breast cancer as well. The same here replicated with chemotherapy, I'm telling. Please mention like it's a chemotherapy. So, but the compliance to chemotherapy, the toxicity of chemotherapy is much better in patients who received in neoadjuvant setting than the adjuvant setting. And the benefit is like started opening the Towe et al. In T4. The T4, we all know there is a lot of dicey situation whether to give before or not, whether to give neoadjuvant or adjuvant. They studied after giving neoadjuvant, there is significant improvement in the resection rates. That's a positive margin is got decreased, as well as overall survival got increased by giving neoadjuvant therapy. This was the most talked paper than in surgical peers. I'm sure Kumar sir will agree with me. In LACE meta-analysis all the time when we meet the surgery peers, they do say just 5% benefit. But things changed over the time. From my residency first year till now, a lot of things has changed in lung cancer. And coming to the prehabilitation, not just the treatment, but prehabilitation is also very important in lung cancer. As the time progresses, if you give 4 weeks of rehabilitation, the patient will have a good post-op recovery. And meta-analysis on neoadjuvant therapy, which was published in Lancet 2014. So it included multiple trials, but 15 RCTs got included and 2,000 odd patients got included. The outcomes were again 5% benefit, similar to the adjuvant therapy in this as well. There is no difference in the both neoadjuvant and adjuvant outcomes. The preoperative chemotherapy was beneficial in distant metastasis and very good compliance got noted again in the RCT. So what's the rationale for neoadjuvant therapy? Immunotherapy. My friend Mridul now, I think he must be shivering now. So if you see the neoadjuvant therapy, there's significant neoantigen load is there. In immunotherapy, we all know the biology of immunotherapy is like to prime for the antigens. So if I give a neoadjuvant therapy, lot of antigen load will be there and the T cells will get primed easily. The similar thing was published in Journal of Immunotherapy. That's a better priming. Tumor will be less heterogeneous if we start early, and the access to pre and post tissue and ability to assess the efficacy of therapy is very high if we initiate neoadjuvant immunotherapy. And also, after this, both chemotherapy and immunotherapy, the costly treatment has come. So pathologists were forced to work more. So they came up, the Travis et al., they published that PAT-CR as well as major pathological response are very important in lung cancer. PAT-CR, we all know, no viable tumor cells, and major pathological response less than or equal to 10% viable tumor cells are noted. Not only that, they correlated retrospectively. There is a difference in outcome with the patient who attained major PAT-CR versus no PAT-CR, no major PAT-CR, in both squamous as well as adenocarcinoma. And these are the phase 2 trial. Out of this, the one stood like prominent is an ADIM trial. And these are the phase 3 neoadjuvant trials. Out of this, Checkmate 816 stood so prominent. And this is a phase 2 data of nivolumab alone. Remember this, in phase 2, initially they tested only nivolumab. It's going to help us in the patients who are not fit for chemotherapy. And again, they tested both immunotherapy plus chemotherapy combination. There's an ADIM trial, which is a path-breaking trial, which led to Checkmate 816 result like more prominent. So if you see this one, for it all, there's just 2 doses of nivolumab and 2 doses of atezolizumab. There is significant major pathological response and PAT-CR got noted. And later, atezo plus CT Shu et al. So still, this is not so mature, but again, the striking results were there. What's more important in ADIM study is all patients are stage 3. So the outcomes, we know that outcomes of stage 3 is very dismal. Lot of gray area is there, like how to treat these patients. So just 3 cycles of chemo plus immuno was given. Later surgery was performed. Again, 1 year of nivolumab was given in this study. If you see the outcomes, that's a PFS, OS, surgical outcomes, everything. There's a good PFS got noted, both intention treat as well as per protocol analysis. And OS was significantly, starkly outstanding. And if you see the neoadjuvant adverse events, the neoadjuvant adverse events are pretty low compared to the adjuvant adverse events in this study. So which is like really to be noted. And also the PAT-CR rates were as high as 63% in the NADIM study. Coming to the Checkmate 816, I'm a strong proponent of minimal therapy. If you are so, this trial is going to help you to tailor the treatment. So what's the Checkmate 816 design? It's a stage 1B to stage 3A. It's not just stage 3 like NADIM study. Here, Nevo plus chemo 3 cycles versus chemo followed by surgery, optional adjuvant therapy. There is no 1 year of nivolumab got included here. That's really beneficial, both financially as well as toxicity profile wise and compliance wise. If you see here, again, the stage 3 is the major chunk constituting 60% of the whole population. And 94% compliance to treatment is there. 94% people completed the neoadjuvant treatment. And also if you see, all the subgroups got a significant benefit. And the hazard ratio is 0.63 with 31.6 versus 20.8. If you see the PD-L1 more than 50 got more benefit and more stage, as the stage increases, the benefit is more. The PAT-CR, major PAT-CR also significant. So, and stage 3 got more benefit than the stage 1B2, but still the benefit is really stark. And OS, though it's not mature, but still it's really promising. So the surgery, already Dr. Sabita told, I'm not going to stress much on it. There is a less pneumonectomies, less like adverse events, less disease progression, and the conversion rates were very less in patients who received Nivo plus chemo. And ctDNA clearance were pretty high and correlated with PAT-CR. So adverse events like pretty low because only just 3 cycles of Nivo was given. So what about target mutations? I am sure Mridul is going to target me regarding this. Mridul, I will meet you next time with this trial regarding targeted mutations. As of now, non-targeted. What is Mridul going to discuss? IM power 010 Pearls trial. What are the pitfalls of it? If you see the IM power 010, though it got approval, the hazard ratio is really not appealing to me. And Pearl trial, again the same. The hazard ratio is not really appealing. More than that, the interim OS analysis, they say it's immature, but again, it's not so significant. Coming to the keynote 091, all of us will be reading from the back then. As the PD-L1 percentage is more, the response will be more. As the stage increases, the response will be more. But here, if you see keynote 091, stage 3 got a less benefit compared to stage 1B, stage 2, and PD-L1 more than 50% patients got less benefit. And again, compliance, the compliance is not good. Almost half of the patients opted out of the treatment. Coming to the adverse events leading to atezo discontinuation and pembro discontinuation as high as 20%. So what is the conclusion summary? Pearl trial, Empower trial, the statistical significance boundary for DFS was not yet crossed. And out of these 3, the winner is Checkmate 816. So the PAT-CR rates were high, the compliance is high. 54% of NADIM trial patients had multi-stage N2. Almost 50% of Pacific trial patients had stage 3 disease. Were these patients operable? We have to see. Future is tailoring of treatment and duration depends on ctDNA, pathological response and radiomics. After this discussion, I'm sure all of you looking at Checkmate 816 as Bahubali, and Mrudul's discussion is going to be Balal Dev. And all of you are like Anushka, looking at him, going to look at him like that. With this is my debut debate. Thank you, Kumar sir, for this opportunity.
The second part of the debate. So I request Dr. Mrudul Sharma or Malhotra, who is a senior consultant medical oncologist at Paras Healthcare.